I'd like to welcome you all to the first working group meeting. It's a combined working group meeting for working groups 1 and 3 in the COVID and Cancer Global Modelling Consortium. My name is Karen Cantwell, and I'm standing in really as a co-chair, and I'd like to introduce my other co-chair, Dr. Freddie Bray from the International Agency on Research on Cancer. And I'd also like to particularly welcome Prof. Richard Sullivan, who's joining us from the broader task force to update us on the task force activities. So thank you very much. I hope that you are all well, that your families are all well, and that your colleagues are well as we go through this crisis together. And just to say how enormously heartened we have been to see the response to the call for interest in the work of this consortium. So this is the first of 2 calls that we will run. The next call is in approximately 15 hours. And what we tend to find on the calls is that this time will be more attractive to our European and Australian Asia Pacific colleagues, but the second call time works better for our US and North American colleagues. So on the next call, I'll be joined by Dr. Ophira Ginsberg, who's going to be chairing our prevention stream of work and helping me co-chair that meeting on the next call. So just a couple of housekeeping items before we get started. If you could, as always, keep yourselves muted unless you're speaking, that would be fantastic. As I've said earlier, if you haven't introduced yourself already, please use the chat box to do so, because unfortunately we won't have time to run through in-person introductions for everybody. And if you could also use the chat box to log questions as they occur to you as we go through, that would also be fantastic, because we will be scanning and looking at those when it comes to the discussion session. As always, we will try and leave as much time as possible for discussion, but we actually have quite a lot of material to run through today. So I'm going to ask all of the presenters to do their best to to run through their slides quickly. So you'll see now our agenda. We've got quite a lot up for discussion. Firstly, Richard will give us an overview of the COVID-19 and Cancer Task Force, and I'll follow that with an update on the broader CCGMC activities. We do need to run through quickly an update on the draft terms of reference for the CCGMC and the disclosures for those in the working groups present. Then we'll go through some thinking on the intended goals and actions for these working groups, a review of the platforms and some early published results from modelling in this space, concept for a new global platform, discussion of potential data sources, and then we'll have time for discussion, questions and perspectives, and talk briefly about our future call schedule and any other business. So I'd like in advance to thank all the presenters today, which include Dr. Julia Steinberg and Dr. Michael Caruana, Senior Research Fellows at Cancer Council New South Wales. Also Isabel from, and I'm so sorry Isabel, I still don't find myself confident in pronouncing your last name, but Isabel, well known to everyone here from IARC, and Freddie will lead the moderation of the discussion. So without further ado, I'd like to hand over to Prof. Richard Sullivan to give us an overview of the task force. And Richard, just tell me when you want the slides advanced. I can go from there.
Absolutely, super. Thank you very much indeed, Karen. Hello, everybody. Lovely to see so many familiar names and faces on the call. Maybe we could go to the first slide, please, Karen. Thank you. So I'm going to give you a very quick outline of this task force, which sort of came together about 3 months ago, bringing together lots of interested friends and colleagues around the world, essentially to address quite a broad suite of issues around COVID-19 and cancer, which I'm going to say have evolved over time as people's interests and particular areas have been flagged up to us. Broadly speaking, we've got 3 major domains which we started with, looking at the direct risk of COVID-19 to cancer patients, modelling, which I'll say no more about now, and then also asking the question about the direct impact on oncology health workers, be they nurses, doctors, whatever. And then we've had a number of other cross-cutting domains that we've sort of started up in the last couple of months. Next slide, please, Karen. So just to maybe briefly talk about the direct risk of COVID-19 to cancer patients, and I know Mika's on the call here, and really she's the leader of this, along with CS Pramish from Tata Memorial Centre. So this really is about bringing together data from various centres to look at whether or not cancer is an independent risk factor. And a number of publications have already come out, but as many of you will know, a lot of these are quite underpowered in terms of numbers. I won't say much more of that. Meek can talk to this. We're really putting together 2 major patient cohorts to look at this in greater depth. And as you can imagine, this is an area of considerable concern, particularly around mitigating risks to surgical patients or patients undergoing therapy, which are extremely immunosuppressive. Next slide, please, Karen. There's been quite a lot of work, of course, been thinking about how the lockdown has impacted our outcomes and services, both in terms of delays of diagnosis and also changes to treatments, delays to treatment or changes to treatment. Could you just go forward again, please, Karen? Just one. Thank you. Just to highlight, and I know Bernard's on the call as well, and I won't say anything more about that because he can talk to this. The Lancet Oncology have accepted one particular piece of modelling work that Bernard Rache and Ajay Agarwal have led on, particularly looking at England and delays in diagnosis to 4 major cancer types. So this is now available online via the LSHTM website. So we've been given permission to put this out early before it actually gets formally published in Lancet Oncology. But again, Bernard can speak to that. Thank you. Next slide, please. One of the other things we're doing is trying to understand exactly what the impact's been on, mainly around actually the psychological impact on our staff. And there are a number of countries now running a particular cancer centre health workforce survey. Chris Booth from Kingston's really leading this, but we're opening this in places like Pakistan, Zambia, and other places. So we're going to have some quite interesting comparative data, I think, coming over the next sort of 2 or 3 months to look at what the actual direct impact's been on the psychological health. Next slide, please. On the other working groups, there are quite a number of them. We've got the Global Qualitative Survey, which has now been done. I think it encompasses, 22 countries now. And Asim Yosef is leading on that and writing that up. I think that'll be out in the next 2 or 3 weeks. Dorothy Lombe from Zambia is leading a very interesting piece looking at silver linings, essentially what practices have changed since the pandemic that we might want to keep in our systems. For example, more telephone consultations, not bringing people into outpatients so much. And this is a nice piece of work. It's about halfway through at the moment and involves, again, the large consortium of countries. On the economic impact, Michael Schlander from the DKFZ is leading this along with Raoul Murillo and Nirmala Bhupati from Malaysia. And that has 2 aspects. One is to understand how the economic impact has happened within cancer centres and the actual cost of treatment, and also to look at the out-of-pocket expenditure on patients and their family. And finally, many will be aware of, well, this has had a dramatic impact on research, and Debbie Mukherjee and Werner from Ghana are actually conducting quite an in-depth piece of work to look at various countries about what the future impact on research is going to be for the pandemic. And there are a number of publications now coming out, mainly in eCancer and through blogs, through different sites, looking at the sort of qualitative impact of what's been happening on a country-by-country basis. And last slide, please, Karen. And then finally, we've been working with eCancer just to sort of pull together webinars and all the papers that we're finding and analysing as we're going along. On the webinar site, there's an incredible amount of detailed information now, particularly from, for example, the Tata Memorial Centre have done an outstanding set of webinars. And we're bringing some medical writers in now to digest some of these webinars and make them available in more easy to access formats, because you can imagine these webinars go on for at least an hour and a half. So that's something we'll be doing in the next month, but really that's going to be the Cancer Intelligence Hub, is bringing together really the best outputs, be they publications or blogs. And that's it really, Karen. That just gives you an overview of where we are. Thank you very much.
Thank you so much, Richard, and I'm sure people may well have questions and issues for discussion later, so I'll just ask you to log those in the chat box and we'll go on. So thank you, that was really helpful, and it's been extraordinary, I think, to see the breadth of the activities that the task force has got underway in such a short time. And of course, our role is in the modelling space. So just to reiterate what Richard has said, that the Global Modelling Consortium, the CCGMC, is one thread of work under the auspices of the task force. And within the CCGMC, as you know, we now have 3 working groups. Working Group 1 on predicting the impact on cancer treatment services, 2 on screening, and 3 on impact on cancer risk and recovery prevention strategies. Many of you, I'm sure, would have logged into the second meeting of Working Group 2, which happened a couple of days ago. And as you will know, we have split into 5 project teams, and I'll just give you a little bit of insight as we go forward into some early results from that group. Just the latest update on the CCGMC as a whole, we seem to have stabilised now at about 250 registrants, which is fantastic. Fantastic representation from 43 countries and 153 institutions. And here you can see the geographical spread of our members. But it is worth noting, I think, that although we have very, very good representation from North America, Western Europe and Australia, there's still probably more representation would be great from South America, from Africa and from Eastern Europe. So if you do know of colleagues in those spaces in particular that might be interested in joining, please do pass along the word. And again, just to recap how our work programs fit together, we, Working Group 1 and 3, will be able to draw on the expertise of infectious diseases modelers, as well as a clinical expert reference group, which can draw on the expertise of the broader task force activities. And there will also be capacity as we go forward to draw on the Secretariat Centre's support for scoping and systematic reviews as groups need them. And our website is now live, so if you want more information on our meetings, minutes, etc., please go to ccgmc.org. Now, I just want to quickly cover off our terms of reference. Those of you who joined the initial calls will know that we've had a draft of this document circulating, and we would like to ratify that within the next 2 weeks. Just to recap, that we have tried to encapsulate in this document an open and collaborative approach, sharing our learnings, co-publishing our work, building capacity and taking the longer term perspective. Also that we're developing tools that will be widely useful for policymakers in understanding the impact of the crisis and the optimum recovery strategies. Now, through the feedback process and the consultation with all of you, we have added some crucial sections to the terms of reference. So I just wanted to point those out. The latest version of the document is sitting in your meeting request for this meeting, so you can read it in detail if you wish. But to note that we now have in the terms of reference a strong emphasis on a cross-cutting equity lens, considering the country income level, cultural aspects, ethnicity, gender and other aspects of equity. We ask industry and commercial representatives to take an observer role in the CCGMC. We've now included a new section on authorship guidelines, and essentially the proposal is to follow standard conventions for authorships, but for those in a working group that aren't authors, they will be acknowledged via the inclusion of the statement on behalf of the CCGMC and the appropriate working group. And also just to note that the working group chairs will determine whether minutes and presentations can be posted confidentially or on our wider website after consulting with presenters, bearing in mind that we will be presenting early in confidence results on a regular basis, and so we will be censoring our public domain presentations accordingly. So please feed us back any further input by this Friday, 3rd of July, and we'll be ratifying that at the steering group level by next Friday. And for transparency, I'd just like to move through the disclosures that the Coordinating Centre has received for this working group. I will not read them all out, but they will be made available in our Teams site. Just clicking through these. Thank you very much for sending in your disclosures. So to set the scene for today's meeting, here's a representation similar to the one that Richard showed earlier. Our activities as a consortium we see as being across the spectrum of cancer control. Ultimately, we aim to characterise the risk across cancer prevention, the change in screening and early detection, and changes in our cancer outcomes. And so this diagram just shows that we see that there are a number of potential mechanisms and pathways by which the pandemic could impact cancer outcomes. And what we've done here is really highlighted how the activities of the different working groups will fit together. So, for example, Working Group 1 will focus on changes in cancer survival and outcomes and mortality. What we have suggested here is that although there are a number of aspects that we can consider in this, that the first priority for our activities should be the direct impact of treatment disruptions. Similarly, for Working Group 2, the screening group, we're well underway with disruptions, characterising the impact of disruptions to screening programs, but Working Group 1's activities will overlap with that somewhat, because we will also be looking at delays in symptomatic presentation. And then for Working Group 3, really our focus initially, we suggest, should be on the effect of risky behaviours during the crisis, although longer term, of course, there would be great interest in the direct biological impact of the infection on cancer outcomes. So I just want to, before we move on, for those of you who weren't at the screening working group call earlier this week, show you some of the early results coming from the screening thread. And just to also point out that the work of the screening working group is a little different in the sense that many are coming in with very established microsimulation comprehensive platforms. And so we've been able to mobilise pretty quickly to do comparative modelling across countries. So this is just a quick example of some of the emergent work which is really being prepared now for publication by the screening stream, which is looking at the impact of disruptions in colorectal cancer or bowel cancer screening programs. And you can see we've got results now across four models and 3 countries, showing some consistency in the effects and crucially showing that the adverse impact on colorectal cancer mortality, even from a relatively short-term disruption, is consistently projected to last over at least 5 to 10 years. And this working group is now working towards characterising optimal recovery strategies. But again, I just wanted to give you a snapshot of what's going on in the screening stream. So in working groups 1 and 3, the intent is that we will focus on bringing together consortium members and teams to jointly construct a comprehensive platform to quantify the effects of the pandemic on cancer risk prevention, treatment, incidence and mortality outcomes. And we've put here some ideas for the initial activities of each working group. We propose, and we'll come back to this in the discussion, that Working Group 1 on cancer treatment and outcomes initially focuses on the following activities. Firstly, we plan to comprehensively reach out to those who've published already modelling or predictions of the impact on cancer outcomes who are not already involved in the CCGMC. Many of those that have published are involved in some way, but some are not, and Julia will present her scan of the literature in this space shortly. We then would aim to collate the available data sources which will be relevant to the modelling exercise, and these would include synthesised data on impact of effective treatment on survival. This could be in fact in the pre-pandemic context, but repurposed for this analysis. We will need, of course, information on the nature of disruptions, the extent, the specific service delivery aspects of that, and timing in countries, and also in fact from the infectious diseases modellers projections of these going forward. Observational data on impact on diagnostic delays and upstaging information on outcomes as it emerges from countries. And of course, centralised registry data collection on outcomes over time, which Freddie Bray and the IOUT team are coordinating. Using these sources of information, we intend to collaborate on developing a global platform which would tap into the expertise and platforms already developed by others for cancer outcomes modelling, either so that we can cross-validate against others' work or to inform the design of what we do. For Working Group 3, we propose these initial activities, that the initial focus is on understanding the research priorities. What should we focus on initially in terms of cancer risk and prevention? And that would include issues around equity in risk exposures and prevention opportunities. We propose initial focus on synthesising and assessing information on changes in risk behaviour during lockdown or otherwise during the crisis. And that would include all aspects of behaviour that are known to influence cancer risks, so including but not limited to exposure to alcohol, increased exposure to tobacco, reductions in physical activity, and knock-on impacts on body weight and BMI. So the information collated will be able to be incorporated in the collaborative model platform that I talked about earlier to assess the impact on cancer risk in conjunction with the impact of treatment disruptions per se. Now I'm going to hand over to Dr. Julia Steinberg now to give us the results of the scan that the Coordinating Centre has done of the literature that's been published to date. Thanks, Julia.
Thank you very much, Karen. As Karen and Richard mentioned, we know that many of the CCGMC members already work in this space of COVID and cancer. And so to support future collaborative analysis and the planning of these, we've started to collect some high-level information on ongoing as well as planned research via a model description form that was circulated prior to the meeting. You can see on this slide that ongoing research projects for working group members include forecasts of the direct COVID-19 burden through infectious disease modelling, as well as analysis of COVID-19 severity specifically in cancer patients, work on the regional impact of COVID-19 on the availability of treatment and specifically radiotherapy services, as well as more general modelling of childhood cancer burden and outcomes. Now, we have received some additional forms just today, including for a microsimulation model for colorectal cancer, the CSC SPIN model by Carolyn Butter, as well as a more general cancer microsimulation model by Andrea Albavi at the WHO. We will be liaising closely with all involved to make sure that all our activities are complementary. And so please do keep letting us know about your work by sending in the model form to the Secretariat. There is a lot of additional efforts internationally to quantify the overall health impacts of the COVID-19 pandemic at large scale, as well as specifically for cancer. So in the next few slides, we'll show some examples of existing work in this space, although it is by no means an exhaustive overview because there are hundreds of papers coming in online every day. So as you are all aware, there's a lot of infectious disease modelling specifically for COVID-19. And here you can see two examples of really large-scale prominent studies that have projected the COVID-19 burden for low and middle-income countries, taking into account the age structure in these countries, the comorbidities, healthcare capacity, as well as effectiveness of potential interventions. And with this and the following examples, you'll also see some peer-reviewed published papers as well as preprints that have yet to undergo peer review. And this really reflects the speed at which new research on COVID is becoming available. Next slide, please, Karen. There have also been some specific models developed for individual countries or geographic areas. And you can see here an example for the USA and the European Economic Area, projecting the number of COVID-19 deaths as well as healthcare capacity and the number of hospital beds required at estimated peak infection for COVID-19. Some of the results of the infectious disease modeling can feed directly into the inputs for evaluating the impact of the COVID-19 pandemic on cancer burden. But of course, the engagement with the infectious disease modelers in the CCGMC will be really key to identify the most appropriate data, as well as inform on future hypothetical scenarios, because we are, of course, by no means through the pandemic, and so the future impacts are still very unclear. Next slide, please. As you will know, there's also a lot of ongoing work to determine which pre-existing conditions predispose people and increase the risk of severe COVID-19 if infected. So this is a very active research space. Some initial work by Clark and colleagues shown here has used WHO, UK and US COVID guidelines to estimate how many people globally are at increased risk of severe COVID if infected, and that due to underlying health conditions. That they estimate that about 1.7 billion people worldwide would be at such high risk, and that includes cancer patients with either direct immunosuppression or with possible immunosuppression due to treatment. Now that is very high-level overarching work, and of course with cancer, our particular interest is a bit more specific than this. So, thank you. This is a study that Richard mentioned in one of his earlier slides, and he and some of the other consortium members have started to look at cancer diagnosis delay in England. So, Richard, do you or Bernard want to add something to this?
I think to speak to the guru on the phone call, I think Bernard, I saw him up there. Bernard, are you there?
Yes, yeah, I'm here, yeah. Just to summarize what we did here, we assume that the route to diagnosis in England were shut down by the COVID pandemic. Then in England, if you what we need to know is there are 4 main route to diagnosis. There's the 2-week referral pathway, the GP referral pathway, the emergency pathway, which usually has the worst cancer outcomes, and then screening. And we looked at 4 cancer, colorectal, breast, lung, and esophageal cancer. And what we assume is the 2-week referral pathway was decreased by 80%, 85% for the period. And there will be a backlog for 9 months for the full year. And then we redirected the patient to the worst pathway, emergency pathway or the GP pathway for the entire year. And we estimated then there was nearly 4,000 additional cancer deaths and deaths due to cancer due to this delays in diagnosis. Then of course this is only simulation. We haven't used data because they are not yet available, but it's based on what we have observed. And the second thing is that we are very conservative here. For screening, we assume that the breast cancer, the screening program for breast cancer stopped completely, but we assume that the natural history of the disease is slow enough not to impact, at least for 1 year, the cancer deaths. But for colorectal cancer, what we did, we assume that part of it, I think it's something like 20% of the tumor will be diagnosed symptomatically, and then we'll join other route to diagnosis and screening. And that's what we did. If you need some more detail or if you have questions, don't hesitate.
Thank you very much. Now, in addition to diagnosis delays, there are also treatment delays that are expected to occur in many different countries. And there have been 3 studies that we've seen that looked at the impact of these treatment delays on cancer outcomes. So the study you can see here on the slide looked at specifically surgery delays in England across 13 different cancer types. And they estimate that a 3-month delay would lead to almost 5,000 excess deaths, with almost 10,000 excess deaths due to a 6-month delay, for example. Another study, thank you, Karen, looked at excess mortality in cancer patients across a wider range of cancers in England and in the USA, again modeling some hypothetical scenarios and estimating that there could be, again, thousands of excess deaths. And also of note, this study used real-time multi-center data in England and Ireland to estimate that from February to up until April, at its lowest, the chemotherapy in England and Ireland has declined by 45 to 66%, and that urgent referrals for early cancer diagnosis have also decreased sharply during the pandemic. And so that there are already visible changes in treatment that will have to be taken into account. And next slide, please. And the final study that we show here is on cancer treatment delays in Australia. And I believe we actually have the senior author on the line as well. Martin, I think I've seen your name pop up. So would you like to say a few words about this work?
Yes, I'm here, and thank you very much for having me here. This is fantastic work that you're doing here. So actually, this is very timely. I just gave a talk about this yesterday in our cancer center. I think one of the main differences with the UK-based studies that I very much appreciate is that we were not able to use actually patient-level real-time data to inform the modeling. So what we did is we assumed a stage shift model to progress to the next stage based on diagnostic and treatment delays. And we made several assumptions using population-based aggregate level data about stage distribution at diagnosis and the consequence of 3-month and 6-month delay in terms of progression to the next stage. And we've made, as in the other papers, we've made a very conservative estimate for a 3-month and a 6-month delay just from a stage 1 to stage 2 progression for 4 cancers, so breast cancer, colorectal, lung cancer, and for melanoma. Based on population level observational data from the US, so the SHEER database on surgical delays to extrapolate the hazard ratio for that diagnostic delay in terms of survival. So that's where the data from to estimate the time to stage progression. And this is pretty much a conservative estimate for Australia for 4 cancers, 90 deaths. And we also did a bit of costing here. So we extrapolated costs for treatment of stage 1 and stage 2 disease for those 4 cancers. And we estimate population level healthcare costs, excess cost to be 12 million for the next 5 years. So that's what we basically did. I'm very happy to share what this is. Of course, this is available. I'm also happy to share the slide deck that I presented yesterday.
Brilliant. Thank you very much, Martin. So we hope with these examples, we've given you a bit of an overview of what's available in the COVID and cancer modeling space so far. And as we'll discuss later on in the call today, I think we envisage that our work on cancer and COVID will fall somewhere in between the very big picture burden of disease approaches and also the very in-depth microsimulation modeling for specific cancers and countries on the other hand. For discussions related to Working Group 3 and long-term risk changes and prevention, we also wanted to mention that there's a lot of ongoing work by many researchers, charities and public health bodies to quantify the behavior changes during the pandemic, including cancer risk behaviors. For example, surveys in several countries have looked into alcohol consumption during COVID-19 lockdowns, and the initial results suggest that sadly, some people have increased their alcohol consumption quite considerably. For example, it's estimated to be about 1 in 5 in the UK, New Zealand and Australia. Clearly, there are similar concerns around tobacco use, lack of physical activity, obesity and other cancer lifestyle risk factors, and also whether some of these changes would persist over the long term. And consequently, the impacts and the potential impacts on long-term cancer risk can be substantial and will really be key to evaluate and prepare for the COVID-19 recovery and prevention efforts in the long term. With that, I'm handing over to Dr. Michael Caruana to present the concept for a new global cancer and COVID-19 modeling platform.
Thank you, Julia. Today, we thought we will share with you some initial ideas we've had about where we could start building this global modeling platform. And the idea here is that we wanted, the first research question we thought of was, can we quantify the change in the number of cancer deaths and the number of life years lived due to the COVID-19 pandemic? And to this end, we came up with this structure. As you can see, it's quite general. It's not specific to any cancer, because not a specific country, because our aim is to have a platform that can handle multiple cancers or like many different cancers and be applicable to different countries as well. So the idea here is to start with a prevalent cancer case, and then that case can either become infected with SARS-CoV-2 or not infected with the disease. If they're not infected, their survival might still be different because due to the pandemic response, cancer survival might change. If, on the other hand, they are infected with the disease, they can either die from from COVID-19, and we would like to investigate that, or else they can die. Either their cancer survival again will be could be different because of the disruption due to the pandemic response. Now, these quantities would then be compared with the counterfactual of their death if there were no pandemic. And we hope that we can leverage data. Even so, the idea will be to have this flexible platform that can use data as it becomes available, either from the literature or from new data that is collected. But we can also use pre-pandemic data, where we look at situations where we had low uptake of treatment, so that we have an idea of what that would entail. So that's what we're hoping for to do in the first case, and then to link our concept with the work of Working Group 3, which is looking at the risk factors. We hope that in the long term, Working Group 3 would be doing the modeling related to risk factors, but then that would feed into the work and the global platform that has been developed by Working Group 1, so that we will basically model not just the effects of the pandemic in the short term, but also in the long term effects due to changes in risk. So that's our the structures we're thinking of right now, and I guess now I can hand over to Isabel to talk about data sources to inform these ideas. Thanks.
So, good morning and afternoon, everyone. So, I'm Isabel Suryo-Mataram. I'll present very quickly to you what we have as initial ideas of the data that we will be using in this modeling exercise. The idea is then to use as much as possible in the global platform national estimates to make sure that the data and results that we present at the end are comparable. But this will be then complemented, of course, then with observed data. So then please do send us, again, this is a gentle reminder, if you then have data or results or information that we can use to improve then the model, because we're going to be doing a range of sensitivity and validity exercises to make sure that our estimates at the end are as robust as possible. So thinking of the first work group on cancer treatment and outcome, simplifying the data availability, we're looking into then 3 levels of data. So the first part is then on the cancer burden itself. Here then what we're looking into then is incidence, mortality and survival data. We'll be using the national estimates, but also observed data, mainly then taken from data that is representative of the population. So here we're talking then lots about population-based cancer registries. I see just now then comments on decreases of cancer incidence that we started to see published in the literature. So indeed, we've been seeing decrease in cancer incidence, not only lung cancer, but also a range of other cancers. So we've been doing surveys and trying then to also then continue up, monitor then the trends over time, also then to be inputted and taken into account into the modeling. The next part then for the work group 1, so on cancer treatment, of course, then we'll be looking into then data on cancer treatment. So again, then looking into then treatment changes among cases, but also then looking into the pathway to treatment that, as presented before, has changed. For example, looking into delays and how this may impact survival. Finally, then picking up on impact on cancer with and without patients with and without COVID, we'll be looking into the literatures and data on infectious disease and cancer patients specifically. Karen, next slide, please. On the work group 3, looking into cancer risk factors and then also then impact of prevention and how we can then mitigate the long-term effect. Again, we'll be using then cancer estimates data at first, looking into national estimates, but also then observed data. Here then we're more focused on risk factors data. So the next two data items are then related to risk factors. First, looking into risk factors prevalence, so the proportion of people with different risk factors. We're looking here into national estimates, but again, we're hoping then to obtain data also then from observed data. And we'll be also looking then into the changing of these risk factors during during the lockdown and afterwards. Finally, we need then the data that relates the risk factors to cancer risk. So this is then the relative risks. We have done a lot of sources for this, as this is then a common work that has been done and then coordinated by a lot of different groups globally. So looking into, for example, then the continuous update from WCRF, and then we'll pick up then those sources of data. Thank you. I'll hand over now to Richard.
Karen, you're on mute.
I just realized. Thank you very much to all our presenters, and thank you very much for all the work that you've done. And look, I think we do have a good 15 to 20 minutes for discussion. So I'd like to hand over to Freddie, who will moderate, and Freddie, I'll assist you by monitoring the chat box. So thank you very much, Freddie.
Brilliant, thank you, Karen. And just speaking for IARC, the International Agency for Research on Cancer, I'm really pleased to be part of this consortium. I think at its heart, it's really trying to develop a community response to the pandemic, and this principle of having an open and transparent, collaborative approach to supporting decision-making by governments in the wake of the pandemic and its impact on cancer is really just the way to go. So we've had a few questions, Karen. I mean, I have to say that Richard's been great in answering a few of them, but we'll just go through maybe from the most recent one. This is one from Janine Figueres, asking really about treatment. And are we going to look at alternative treatments as well? Will that be taken into account in the modelling? So are we going to look at the span of treatments and the impact on cancer outcomes? I don't know if you want to take that, Karen, or I'm assuming we're going to look quite broadly at therapy and all the other interventions in the
yeah, absolutely. I think I think absolutely is the answer. And I think that we'll get to it at the very end of the session and the wrap up, but the next steps I think will be critical for the two working groups to evolve and to have an extended discussion of the priorities and the order of prioritization of the research questions that we address. But certainly it's not just treatment disruptions, it's treatment changes. And it's even, I guess, in some context, it's you know, one of the silver linings that has been made is that this is accelerating some progression or acceleration of treatment changes that may be desirable. So I think all of those aspects for treatment definitely fit under our remit. But for all of it, it will be very contingent on the data sources. So we do see this as an initial focus on the technical side is getting the platform built and maybe doing some, as we've done in the screening working group, doing some more exploratory high-level analyses that may have to make more assumptions about future disruptions and their impact. But as we go forward, the model will be more and more informed by the data, including the subtleties of treatment, alternative treatments and uptake. Mm-hmm.
Brilliant.
Others may want to comment.
Yeah, and we've just had also a message from Andrew Bowie from WHO, and he's stating that the WHO IARC model is also able to capture the alternative treatment regimens as well, including things like treatment interruption and treatment abandonment. Andre, do you want to speak to that very briefly, or?
Yeah, just to reiterate what Karen said, we don't actually know what the treatment alterations are at the country level. We're working with some of the professional societies that have proposed different regimens, including what we've seen from UK NICE and other normative agencies. And as a starting point, assuming that those mitigation strategies could be implemented to better understand what would the effect be on the health system in terms of hospitalizations, the number of chemotherapy doses, etc. So these are very important points, and just want to acknowledge the comment that was raised. And it is something that we are building to the model now.
And Andre, perhaps while you're with us, for those that couldn't join our very first call, we were really delighted that you were able to present the WHO platform that you've been developing. And I think as we go forward, this ongoing dialogue with WHO about the the ways that our approaches can share data and fit together and complement each other will be so crucial. So we're very grateful for you and the WHO team to be a big part of this consortium.
Thanks, Karen. We feel the same way as what Freddie had said earlier. It's a privilege to be part of the group, and we are so happy to see this consortium emerge. There is a modeling consortium with WHO that's now trying to bring together all disease-specific programs. And of course, the HIV, TB, malaria communities have many people. But this is the only one for NCDs, so really we congratulate the steering committee. And what we can do as a liaison is to ensure, again, the assumptions that we make from this broader modeling consortium align with the assumptions that are being made here as it pertains to treatment interruptions and other impacts on cancer diagnosis and treatment. And WHO and partners have a pretty robust database now on specific disruptions, which we're also happy to reflect on with this group.
Fantastic, thank you so much.
Yeah, thank you, Andre. And we're also, as ARC, as part of WHO, been very happy to work with you and Melanie Bertram in your normative work supporting member states. There's been quite a lot of discussion about, I guess from Bernard Rashi's brief intervention looking at diagnostic delay in England and the impact on lung cancer incidence, and this is an impression that there has been declines in the incidence. I think Isabel alluded to this too, but that chat's actually been done in real time. So there's been some interventions again from Richard and Martin and just discussing that. So I think that's been taken into account. I suppose we have a few additions now coming in. I'm just trying to follow some. We've got one from Joanne Aiken. She's the president of the International Association of Cancer Registries. I guess speaking to Isabel's presentation, Joanne was asking, will data from the population-based registries be available rapidly enough to be useful for the modelling? So this is a important question. This is a challenge for
the $64,000 question. Yes.
But maybe Isabel, do you want to just have a quick answer to that, and myself, and maybe Joanne would like to speak to that too.
So it is a difficult question to answer at the moment, but we are looking at a lot of changes in terms of the cancer registry practice, whereby maybe some of you are not aware, but that there are sometimes longer delays for which then cancer registries can complete the whole population counting of cancer cases or recording of those cancer cases until then the reporting, and usually it takes 1 or 2 years or even longer depending on the resources and settings, of course. But what we are seeing today because of this coronavirus, a bit of a change from the push of the government, but also then a lot of other stakeholders who are interested in the data of coronavirus, whereby then we are seeing that data are coming out quicker. So at the first instance, I can imagine that we will be basing a lot of our exercises based on available data. But then I can imagine as well that this whole exercise is a moving and a living model, whereby then every time we have new improved data, we'll input that into the modeling and take that into account. Karen, maybe you want to comment into that, or Freddie?
Yeah, absolutely. I think this is almost for Joanne, and I think, Joanne, we're really happy to hear your perspective directly, by the way, if you wanted to comment. But I think we see this almost as a maturity model type of approach. So you know, we start with fairly crude assumptions. you know, in the first instance, we hope to access data from surveys of cancer treatment disruptions that are being done at the centre level, including by the task force, as one of the activities that Richard mentioned at the beginning. And we will be able to tap into that data, which is actually coming online now. But clearly, I mean, the ultimate is to move to population level registry outcomes and information there. So I think it's just as the information comes available, we will be using it as quickly as we can. And in the meantime, we're gearing up to be a sort of flexible, reactive platform.
Thanks, Karen. I think that this may be one of the silver linings, in that this really gives us an opportunity to advocate, which we've done for so long, on the importance of getting more rapid data out of cancer registries. There could be no better case study of what this rapidly available data can be used for, and it certainly doesn't need to be checked and double checked to the level of quality that we're used to in order to be able to be useful for these models. So it's I think a good thing to see. Hopefully in the future this will improve. Thank you.
Absolutely, and I sorry, Freddie, but you may want to comment. I mean, there may be a role that this group can see almost in what you might call an advocacy space along those lines at some point, if it's appropriate to make that point in the literature and through our networks of the crucial impact of these data.
Yeah, I mean, absolutely. So these are all great points. I mean, I think this is a global consortium, and looking also at low medium income countries, and there's huge challenges that the survey that Isabel alluded to is showing in terms of the registries being able to collect the information on cancer cases during the lockdown in many countries, or registries being closed, or hospitals being closed. So that also has to come into the frame too. And I think Karen's mentioned this in her presentation. I mean, we really are in for the short term, but also the long term. We really want to see the impact on risk and income outcome. I mean, over the next years, we know it's not just going to be a temporary transitional piece where there are minor impacts. Potentially, this is having a greater impact over many years, and the registries are going to be critical. Hopefully, though, it is one of those silver linings where we can get more rapid data. On a different tack, and I guess this is one for our colleagues in Sydney and Karen, this is from Nana Barathri. Is the integrated or shared platform being built at the moment? That's the question. Is the integrated or shared platform being built at the moment? Are the resources available now for its use? These are two sort of critical questions. I guess you're building the global platform as we speak, Karen, you can speak to that. But what about the sort of resources around this as well?
Yeah, that's a great question and complex to answer, and it's an evolving discussion. But yeah, I mean, I think the idea, I think, as we said, in terms of the terms of reference for our collaboration, is that this would be ultimately a shared resource for the global community, which would be designed to inform governments and policymakers. That's kind of from our first principles. Yes, it's being built as we speak, and this discussion is part of the design thinking of that platform. And the team at Cancer Council have been working very closely with IARC in thinking through how we could construct and get this up and running. But it's in fact the working group meetings that will devolve into next. So the next meetings for working groups 1 and 3, where we'd really like to involve you all in the detail of that. So again, for those that are able to contribute, we see this as a shared enterprise, basically, to build that system. In terms of what will be made available to governments and how quickly we'll be able to use the platform to address policy questions, I think it is going to be a resourcing challenge. All of this is going to be a resourcing challenge, and we have to, acknowledge that. And I think at the task force level, we've been discussing that all of this is being done on a voluntary basis at the moment. We're all here in a way on our own time or our institution's time. And so it is very much part of our focus going forward to consider opportunities for centralised funding for this consortium to really set us up, in a very sustainable way to develop and use the platform and disseminate the results in the appropriate way. And also, I think we're all very keen, I think, at the steering group level to have this capacity building lens and to ultimately find funding for things like fellowships and training opportunities for early career researchers and students that might be interested in taking part in some of the activities that we're involved in. So that's a very long answer to a short question, but certainly we have a long way to go, and that's partly why we're here for the long term. But yes, this is all in play as we speak.
Brilliant. Well, that's I mean, I think there's ongoing chat, I think, about treatment regimens and some of the issues, and I think some people are having to leave. It's getting close to 10 o'clock. Just, we had one comment from Mark Clements, who many will know, just a comment on the model predictions. I'm just trying to find it, the screen keeps moving, but the comment was that the model predictions are for hypothesized rather than empirical disruption effects. So that's just a comment for you, Karen, to take. But I'm not sure we've got any more questions. I'm just going to check again.
Yeah,
I think we're almost done. So maybe you can sum up and talk about the next steps, Karen.
Sure. Thank you. And just very quickly, I'm happy to talk to Mark offline about his comment and just check which slide he was referring to. But in terms of the screening program, the CRC screening disruptions that I showed from Working Group 2, they definitely are hypothesized predictions at this point, just as a way to get started, again, with the idea that we'd be informed by the data as we go forward. So just very quickly then to wrap up, just to let you know about the next step. So as I've alluded to several times, each working group will aim to hold a call for more detailed discussion within the next 2 to 4 weeks. We'd like to say it was next week, but realistically it takes a while to find times that work for all in all of our busy lives. So expect a doodle poll from the Secretariat for the next steps for the working group calls. And the Coordinating Centre will continue to follow up with completion of disclosure forms for any that haven't completed that process, to make sure we've got the audit of all model platforms brought in by group members. And also we have set up a shared workspace for the consortium, which enables us to confidentially share files and insights and meet on Microsoft Teams. So please expect an invitation to that shared workspace. And also just to let you know that we were originally thinking of having a full consortium call across all 3 working groups next week, but given that we've now managed to, this week we're meeting across all 3 working groups, we're going to postpone that whole of consortium call and come back together at a time in the next month or 2 where we have some initial results to present to each other. So with that, I'll just ask if anyone would like to raise any other business. Great. Well, I'd like to finish by thanking you all very much. I'd like to especially thank our consortium secretariat, Harriet Hui and Catherine Barron, who do so much work to organise these meetings. I'd like to thank all our presenters today, and I'd particularly like to thank my co-chair, Freddie. We, as always, it feels like we've only barely touched the sides with these discussions, but we hope to follow up and deepen the discussions in the next meeting of the working groups. And thank you all for your enthusiasm and for your involvement.